All right, the next talk is entitled Contact Tracing for Healthcare Workers in an Intensive Care Unit.
Hello, everyone. So I'm Chen Yang Lu. I'll present on behalf of this large interdisciplinary team from computer science and infectious diseases, as well as the newly established AIM Institute dedicated to AI and IoT for medicine. So our project conducted during the pandemic was aimed to protect our frontline healthcare workers in the hospital environment. So there's several important features and requirements of our project. First, it turns out one of the first things that we learned as we try to do this in a hospital environment, and specifically the COVID intensive care unit, it turns out we cannot use cell phones, right? All these works that our community did, right, developing apps for smartphones using the Google Apple protocol, turns out it's not applicable in this environment, primarily because of infection concerns, right? So in these very sensitive environment, clinicians are not allowed to bring their smartphones or other objects, right, into the unit. And of course, there are privacy concerns as well. And then, interestingly, there's a lot more interest in detecting clinician-to-clinician transmissions. So it turns out there's less concern about the interaction between patients and clinicians, because in these COVID ICUs, right, the clinicians are in the full gear, right, fully protected as they enter patient rooms. So they are actually less concerned about infection in those interactions. They are a lot more concerned about accidental transmission of the virus between clinicians, right, as they interact in their daily lives. So because we cannot use cell phones, we opted for cheap BLE beacons, right? Basically, these are right, tiny button-sized devices where when the healthcare workers come to the unit, right, they put those tags, right, beacons into their badge holders, right? So then they work around the environment, and then there's a network of Raspberry Pis as anchors deployed in the clinical unit to pick up the beacon messages from these badges, and then detect close contacts between clinicians, right? So they send these information, right, to the edge server. The edge server supports these queries where you simply provide a target user who may be infected, and then provide a date range. Then the system will generate an automated, right, contact tracing report, right, so that you can quickly find out, right, how many people were in close contact with this infected person within the last 2 weeks, right, for example. The catch system was deployed in the COVID ICU in Barnes and Jewish Hospital, and 187 healthcare workers participated in the clinical study. So this is very much a real-world study. So as we look at, so we did site survey. So this is the COVID ICU where the study was performed, right? As we did the site survey, right, of the environment, we quickly realized this is a very diverse set of scenarios that we need to do this in, right? So there are, easy open space rooms, right, such as the conference rooms, where your Euro localization solutions would probably work well. But then there are structured rooms, right, such as the workstations for the nurses, right? These are environments where there's a lot of computers and furniture. It's a more complex environment where it's typically a lot harder to perform accurate localization. But the good news is these are also the kind of environment where it's very structured in the sense that if a nurse is in that room, chances are they are in front of computers, and computers are in known fixed locations, right? It's a lot easier to localize people, right, to this discrete set of known locations, right? So that gives us opportunity to do a much better job, right, despite, right, the obstacles and complexity in this space. But then hallways, right? So hallways are dreadful places for localization, right? So these are long and narrow spaces where you have only 2 lines of sparsely populated anchors. But then we realize, right, so the health worker behavior in these hallways are very unique, right, in the sense of most of the contacts that happen, right, between healthcare workers in the hallways are the so-called patient rounds, right? So these are basically healthcare workers, physicians, nurses of different roles, right? They form a team, right? So then they walk through the hallway, visiting different patients, right? And discuss their case and decide the treatment plan, then move on to the next patient, right? So most of the close contact, right, between healthcare workers in the hallways turns out are just these patient rounds, right? So if you think about these patient rounds, these are clusters, right? These are clustering behavior, right? So it's a lot easier to detect clusters of people based on their beacon messages than localized individual person in there, right? So just give you an example. So the big insight from this study is you need to tailor your methods, right, to different scenarios, which are quite diverse, even in a single ICU. Right, just give you a little example of the kind of performance you can get, right, through these innovative methods tailored for specific environment. So this is hallways, right? So this is to detect clusters in the hallway. So on top, right, so these are sort of core members or permanent members of that patient round. Here in this picture, you can see those, dark black line on top, right? These are the ground truths, right? Of course, for this group of core members, they are permanently member, right, of that cluster, so they are always in close contact. That's why you see that black line is always on top, right? And performance-wise, the green area refers to the cases where the clustering algorithm correctly classified the users as in the group, right? So versus the purple-ish area are the occasional cases where the clustering algorithm did get it wrong, right? But it mostly get it right. On the bottom part is a little more interesting case. These are members who are only in the group sometimes, right? These are, for example, nurses responsible for specific patients, and they would join the group only when their patients are being discussed, right? So basically, you'll see, that's why you see that black line going up and down, right? Because when it's up, that means they are part of the group, right? When that is down, means they are not, right? They left the group, right? Again, you see in the first and the third temporary members, the clustering algorithm got it wrong, got it correct, right? But versus, right, in this middle case, it did get it wrong, right? Just a quick cap of the case studies that we did, right? We had the attending physician simulating standard contact tracing practice by memory, by journals, and so on, right? So the catch system ended up automatically estimated 31 users were in close contact with the physician, including all 27 users listed, right, by the attending physician, potentially identifying 4 more that the physician overlooked. We also did this study where different healthcare workers with different roles. We show that, right, it turns out the number of close contacts are compliant with our expectations. With attending physician tends to have the most contact, and followed by the resident, and so on. And you can do these contact tracing in tens of minutes instead of 3 days, as in the manual contact tracing. I'll leave this summary here in the interest of time. So, if you have any questions, I'm open to one now. Yeah.
Yeah, thanks a lot for the really interesting presentation. So just quick question. So you really deploy the system. So for actual contact tracing, so do you also develop some sort of software so identify who are in close contact and so on? So did you do that kind of real user study? I mean, like real tracing part.
Right. So yeah. So we did 2 types of study, right? So the real difficult part of contact tracing studies in a real world clinical unit is you don't have ground truth, right? So basically, that's why we basically did two types of studies. One is controlled studies, where we have study coordinators, observe, right, contacts, right, for a certain period of time, but not continuously over months, right? So, but then we also did this subjective case study where it's comparing our results against essentially the standard practice of contact tracing. Thank you.